Go.
Yeah, go, sir.
I'm very happy to be here today to share with you my thoughts on critical care nutrition updates. And I will give you the reality of the situation and the myths that still exist here. Now, some of you in the audience might have already heard this presentation in some point or in some form or fashion. And so I'll try to make it as interesting to you and give you some new evidence that has come up in the last few months. My learning objectives are very simple. Rather than listing a huge bunch of learning objectives, my learning objectives are simply going to be how do I give quality health care to a patient at affordable cost, and how can I safely provide nutrition to critically ill patients? I have no disclosures pertinent to this talk, and no brand names will be used, and there is no intention to directly or discreetly to promote any products of any company. You can use the products of any company you want at the end of the game. Now, patients don't die in hospitals because of a major error that has occurred in their care. It occurs because the system has failed in the hospital. The system of identifying malnutrition early, and the system of letting dietitians and other physicians knowledgeable in the management of critical care do what is right, rather than listen to physicians who may be politically well connected within the hospital administration, but who may not know much about nutritional practice itself. So it is not because of physician errors, but because the hospital has failed to understand the importance of nutrition. And we do know for a fact that malnutrition results in poor wound healing, increase in infections, the convalescence time goes up, the cost goes up. And this results in readmission to the hospital, increased mortality, various forms of new treatments have to be started because of the complications, the length of the stay in the hospital goes up, naturally the cost goes up, and the quality of life goes down. So malnutrition somehow has to be combated. We have to realize that 20 to 50% of patients are malnourished at the time of admission to the hospital, but worse still, during the hospital stay, many patients who have a normal nutritional status decline during hospitalization. And very often, after discharge from the hospital, nutrition is not very well attended to. Advice to patients about malnutrition after discharge is not given as much as wound care and mobilization and various other aspects of patient care. The confusion about what indeed is malnutrition exists because there is a disconnect between professionals. Dietitians think malnutrition means one thing, physicians think it is a different thing, and different dietitians and different physicians of different specialties have various ideas about malnutrition. The traditional understanding is, of course, pure starvation. But presently, there are several definitions of malnutrition, but the diagnosis is not always very obvious, especially in obese patients. And this is what we have to be very worried about. Malnutrition is often neglected in obese patients because it is not detected. And to make things easy, a global leadership initiative on malnutrition was taken, and these are known as the GLIM criteria. For the first time, it picks up disease related malnutrition, not related to weight loss alone. Now, this incorporates several features of earlier consensus definitions, and I would urge you to stop all other methods of nutritional screening and assessment and just use the new GLIM criteria. Screening can be done with various simple criteria, malnutrition screening tool or something that you may modify in your own hospital. But after that, a detailed assessment should be done using the GLIM criteria. And this slide shows that the GLIM criteria makes life easy because it divides the criteria into etiology and phenotypic criteria. Now, etiology is reduced food intake or assimilation, inflammation, disease burden. The phenotypic criteria are the usual ones, the weight loss, low BMI, reduced muscle mass, either by the use of ultrasound or by physical examination. But what is interesting is you need only one etiologic criterion and one phenotypic criterion, and then lo and behold, you have a diagnosis of malnutrition. Now, once the diagnosis of malnutrition is recorded in the patient's medical records, either by the dietitian or by the physicians, then it has to be treated. You cannot have a patient in a hospital where malnutrition has been recognized but has not been adequately treated. This medical malpractice. Like you would not treat a patient in the hospital with an infection and then say, I'm not going to give antibiotics. It's the same analogy here too. And the new GLIM criteria have been created by an international consortium. The definitions have been standardized and publications can be standardized. It depends not only upon etiology but weight loss, and sarcopenia or muscle loss is picked up. No scoring is used, and only there are 2 grades. And because this is an international consortium that has created the GLIM criteria, no longer can physicians or dietitians say those are North American guidelines, European guidelines, not suitable for Asia. It is a way of just saying that I don't know what malnutrition means and hiding one's ignorance by putting the blame on guidelines made by other countries. Whatever be the color of your skin, the malnutrition and the physiology of malnutrition is the same. And therefore, I urge all of you to use the GLIM criteria. It has been used in COVID. It has been compared to subjective global assessment, and it's quite comparable. Strong association with mortality and longer duration of ICU stay. Now, one thing that we have to realize about malnutrition diagnosis is that lab tests are not needed. Don't waste your money and the patient's time and effort to get serum protein levels like albumin, pre-albumin, and transferrin. They are not markers of nutritional status, and the 2016 as well as the 2021 Aspen position papers clearly states that a low albumin level is a marker of inflammation and not malnutrition per se. And therefore, it may reflect mortality, that is true. But a normal level of visceral proteins such as serum albumin does not rule out malnutrition. If you want to pick up inflammation, you can do other tests such as C-reactive protein and leukocytosis at a high glucose level. But albumin level is absolutely useless. And worse still, many physicians in our country and many Asian countries give intravenous albumin to correct malnutrition, which is absolutely not indicated. Now, I want to take up a myth now. In previously well-nourished patients, it takes several days for malnutrition to manifest. Is this correct? Obviously not, but I'm going to convince you. When you do not have time for breakfast and you do not have time for lunch, you have a peculiar smell in your breath when you go home. These are ketone bodies that comes from the breakdown of fat. Whereas when you have inflammation or trauma or sepsis, the breakdown of fat, ketogenesis, is actually thwarted. It's cut down, and gluconeogenesis occurs from muscle, smooth muscle, as well as the voluntary muscles to produce glucose. Protein is broken down at alarming rates. And as you can see in this slide, on the left side, in normal starvation, fat is broken down. In sepsis and trauma, protein is broken down. And this is an auto-cannibalism. For you to get 14 kilocalories, which comes from 3.5 grams of glucose, you need 1 gram of nitrogen or 6.25 grams of protein. And in this calculation, you can clearly see that if you have to provide 150 grams of glucose, which is the minimum you need every day, you will have to be breaking down 675 grams of wet protein every day. Close to a kilogram of protein is broken down every day when the patient is sick. And that is why there is a new guideline which has actually increased the amount of protein you need to give a patient, 1.2 to 2 grams per kilograms of actual body weight. Don't let anybody tell you that when you give more protein, renal insufficiency occurs, because there is absolutely no proof to show that. Even in CKD patients, you need to give more protein. If ultimately the patient needs to be dialyzed, well, so be it. But you cannot limit protein to prevent, to try to avoid renal failure. The renal failure may occur for some other reason, but in a patient in the intensive care unit, you have to give enough protein. Of course, in an obese patient with a BMI of greater than 40, up to 2.5 grams per kilograms are recommended. And these are actually no change from the 2016 guidelines. The 2022 guidelines states that the studies are inconclusive. Some studies say high protein, some studies say low protein. So in general, they say we cannot make changes from earlier recommendations, 1.2 to 2 grams per kilogram. Now, obviously, you cannot give this amount of protein on day one. And so there are some studies that have shown that in the first 1 to 2 days of ICU stay, you give 0.8, and then day 3 to 5.8 to 1.2, and after day 5, 1.2. Now, in fact, this is exactly what happens in real life because you cannot give the caloric needs of patients on day one itself. And so gradually, as you are increasing the calories, you increase the protein too. And here's a nice reference by Al-Dorsey, published a few months ago. Now, what about calories? Now, if you take up the difference between the prescribed calories and the energy you receive from enteral feeding, usually it takes several days before you can reach the goal in earlier studies. But what happens is when you have a calorie debt, you have a longer ICU stay, increased days on mechanical ventilation, increased complications, and increased mortality. And therefore, the new rule of thumb is 12 to 25. You actually, in the first few days, it is okay to give just 12 calories, but you give something and you go up to 25 calories. Do not use predictive formulas. When the higher protein levels are met, then studies have shown well, it doesn't make a difference whether you use a 23 kilocalorie per kilogram formula or whether you are eucaloric at 29 to 30 calories. It is a protein that is more important. People have often asked me, what about indirect calorimetry? Well, if you have it for research purposes, it is fine. But to add extra cost to the patient cannot be justified. And it is not practical in every hospital. So when you have set up the nutrition practice absolutely perfect in your hospital, that is the time to get indirect calorimetry, not before that, and result in greater cost to the patient. Permissive underfeeding is not recommended for extended periods of time. It is only a starting point. And it is only a starting point. You start giving trophic feedings because even with 10 to 15 cc's of enteral feeding, gut defenses are maintained and the microbiome of the gut is maintained. You prevent refeeding syndrome, and gradually you keep advancing from 10 to 15 calories per kilogram up to 25 to 30 calories per kilogram. And side by side, protein intake is also increased. The message is start somewhere. Don't delay enteral feeding. So the truth is, in well-nourished patients, protein energy malnutrition occurs as a rapid rate, and it can occur in all patients irrespective of the socio-economic status. The next myth is parenteral nutrition is safe. Parenteral nutrition is given through unnatural routes and components are artificial. Fiber cannot be given. Glutamine is not always given. L-carnitine is not given. It does not have a first pass through the liver. High incidence of dysglycemia and higher mortality. And the stress response that I'm going to discuss with you again, and which I've discussed earlier, cannot be attenuated by parenteral nutrition. It is only early enteral feeding that prevents the protein breakdown, at least attenuates the protein breakdown. Now, when you give parenteral nutrition, certainly the patient can put on some weight, but the weight is all fat weight, and it is not muscle mass, and it is only the fat content of muscle mass. And studies have also clearly shown that parenteral nutrition doubles the risk of dying. However, supplemental parenteral nutrition can be used in certain conditions where the enteral feeding cannot be reached up to goal within 4 or 5 days. Now, when you have a patient with a high output fistula or a total bowel obstruction, I agree that parenteral nutrition should be started sooner. But in all other conditions, wait for 3 to 5 days before resorting to supplemental or total parenteral nutrition. There is absolutely no term in the literature to say partial parenteral nutrition. It's a very peculiar term that we often hear about. There is no indication to give components of parenteral nutrition, just amino acids or just fat emulsion. If you want to give parenteral nutrition, the entire gamut is given. Glucose, fat, and protein, and you can cut down the volume. That is supplemental parenteral nutrition. No reason to give pure amino acids. Now, the definition of early enteral nutrition is clear by several guidelines, 24 to 48 hours. And early enteral feeding maintains gut function, stimulates contractility, it maintains the mucoid, the mucosa and the mucosal associated lymphoid tissue. It prevents the gut microbiota from being overgrown with pathogenic microbiota, and it prevents parenteral nutrition associated complications. If you look at the small bowel through an electron microscope, you see folds and folds. Through a regular endoscopy, you can see certain folds. But with electron microscope, the folds themselves have folds. And therefore, if you look at the intestine as a smooth cylinder, it's about 3,300 square meters. But if you look at it in terms of the microvilli, it is almost like the size of a tennis court. And when you do not feed the patient, the normal villi atrophies, and through the atrophic mucosa, bacteria and toxins go through the bowel wall and produces the systemic inflammatory response syndrome, which results in the protein breakdown that I discussed earlier. Studies have very clearly shown several years, this study is 20 years old, clearly shows in over 2,000 patients that when you compare enteral and parenteral nutrition has better outcomes. Infection rate is decreased. And of course, showing mortality benefit is extremely difficult. So enteral nutrition should be the primary mode of feeding in the ICU. In our hospital, almost 90 to 95% of patients are fed enterally. Very rarely is parenteral nutrition used. If you use enteral nutrition with greater finesse, you will find less complications and less need for parenteral nutrition. Now, having said that, there are several objections to early enteral feeding. The patient is too sick, or high gastric residue, ileus, anastomosis, family refuses, and these are some of the things I'm going to discuss with you and try to convince you that the reason for not using this is based upon myths and old opinions without resorting to modern views. So one myth is enteral feeding cannot be provided with high gastric residual volume. How many times have you seen nurses stop the feeding because the gastric residual volume is 150 cc's? Now, there is no relationship of gastric residual volume to aspiration pneumonitis, ventilator-free days, organ failure or mortality, and actually studies have shown that there is no need to measure. If you keep the patient's head end of the bed up at 35 degrees and preemptively use pro-motility agents like metoclopramide, and you take all these precautions, you'll find that aspiration is quite minimal, and patients can tolerate intragastric feedings quite well. Therefore, measuring gastric residual volume has been abandoned in many, many hospitals. It is only in certain conditions like diabetic gastroparesis you may want to measure. Even 500 cc's of gastric residual volume is fine, and recommendations both in the 2016 and the 2022 guidelines have clearly stated that GRB should not be used as part of routine care to monitor ICU. Now, bowel sounds and passage of flatus are a huge, huge problem. Both in the 2016 guidelines and the 2022 guidelines reinforce the same principles that bowel sounds are absolutely not needed. But even now, you will see doctors and nurses delay feeding because of no bowel sounds. This is quite ridiculous because the information about not depending on bowel sounds is over 20 years old. I urge the dietitians to have the references in your hand and to convince the nursing staff and also to tell your physicians that it is not supported by guidelines. If the patient is hungry and if all other conditions are met, you can feed the patient enterally. Bowel sounds are not needed for initiation of enteral nutrition. More so, passage of flatus is absolutely not necessary. GI anastomosis is another big problem, and I really pity dietitians who are not able to fight this battle. If you take a bottle of ink and put it into the Bay of Bengal, You're not going to discolor the C. Similarly, adding 500 cc's of an enteral formula to the small bowel fluid, which is over 6, 7, 8 liters, nothing is going to happen. In fact, anastomosis heal better when they are bathed with nutrition. If you take gastric bypass procedures for obesity, you'll find that the entire greater curve of the stomach is stapled off, and yet these patients are fed within a day or so. So why not in other conditions? So this is a huge, huge problem. And again, you need to get the support of physicians, especially ICU physicians, to convince surgeons that this is absolutely not necessary. And it is actually detrimental to patient care to delay enteral feeding. Now, enteral feeding does not mean having a huge masala dosa and some 5 cups of tea or coffee. All it means is 500 to 1,000 cc's of a scientific formula given to the patient over 24 hours. So the truth is, enteral feeding should not be delayed in patients with GI anastomosis, supported by the 22 guidelines, and anastomosis heal better. Now, a few other conditions. This is an open abdomen, and I won't bore you with details to tell you how open abdomen, or why open the abdomen is left open, but it is very safe to give enteral feeding. What about pancreatitis? Again, there is absolutely no indication to give parenteral nutrition for patients with pancreatitis. There is only when oral or enteral feeding cannot be given for whatever reason and cannot be tolerated should parenteral nutrition be resorted to. And intragastric feeding, when indicated, should be given, but you don't need always an intrajejunal feeding now. Polymeric formulas can be used. Don't believe anybody when they tell you that in pancreatitis, elemental or semi-elemental formula should be used. Not needed at all. Regular formulas can be given. Now, about the prone position, you know that during the COVID situation, many patients were nursed in the prone position with the face down. And that is because, as you can see here, the lung volume increases in the prone position. And because the lung volume increases, you will find that the patient's ventilatory status is better. That is why the prone position was used. Now, several papers have clearly shown that enteral feeding in the prone position is absolutely safe, including the study by Savio and Ramakrishnan from Madras itself, and it is supported by guidelines. So just because a patient is in a prone position does not mean the patient should not be fed enterally. Of course, this may be a situation where some patients, where some physicians like to measure the gastric residual volume, or preemptive use of prokinetic agents may be used. But just because a patient is in a prone position, enteral feeding should not be delayed. What about hypotensive states? Hypotension, again, in the critically ill patient, is not a contraindication for feeding. You can use enteral feeding even in patients who are hypotensive, provided the pressures are not, the pressure requirement is not very high, and provide it is not accelerated. These are conditions where you can check the serum lactate periodically. If the lactate goes up, maybe at that time you can think about bowel ischemia, increasing gastric residual volume, maybe a surrogate marker of intolerance. That is another condition. So a mean arterial pressure of 50 millimeters of mercury is perfectly okay to start enteral feeding. What about ECMO, extracorporeal membrane oxygenation? You know that many patients were on ECMO during the COVID crisis. This is the limit. This is a review article because randomization is close to impossible. Early enteral nutrition is safe, provided all the factors about hypotension that I discussed earlier are also taken into account. And you start with a highly concentrated formula, 2 calories per cc, trophic feeding at slow rates. Even permissive underfeeding may be acceptable, but feed the patient. You monitor for mesenteric ischemia. And again, another problem I have noticed is just because a patient has neuromuscular blockade, paralyzed, enteral feeding need not be stopped. So here is a very nice paper in Nutrition in Clinical Practice, published a few months ago, that goes on to all the details. Specialized enteral formulas are not necessary for jejunostomy or for pancreatitis. Hepatic formulas have very, very limited role. Pulmonary formulas have absolutely no indication. Specialty formulas like renal failure and diabetes or stress-induced hyperglycemia are certainly appropriate, but routine use of the specialty formulas are not needed. I want to spend a few minutes to tell you that there are a lot of disadvantages of hospital-prepared blenderized diets, and it's a myth to think that they are actually cheaper. They have unpredictable nutrient content, significant day-to-day variability. They are quite variable in both vitamins and trace elements. They require large bore tubes that can produce erosion in the nose and in the esophagus. Totally unreliable, and it should not be used in the present day. The scientific formulas have complete and balanced nutrition. Osmolality is low, lactose levels are low. It can go through small tubes. It is commercially sterile. Caloric dense formulas are available. It can go very, very easily through small tubes. But remember, the sterility and the flow pattern is what is good, in addition to the formula itself. However good the dietitian may be, blenderized, kitchen-prepared diets can never accurately tell you what the nutritional content is. Now, if you'd like to take in account for the protein content, studies have shown that the protein content that you think the patient is getting is 4.5 grams, but actually the patient is getting 1.2 grams. That is 4.2 grams of nitrogen multiplied by 6.25. This will give you the amount of protein. Suffice it to say that there is a significant variation. So if the patient is getting 1.5 liters of feeding, then 51 grams of protein a day are not being given to the patient, whereas you think that the patient is getting that. Microbial contamination because of food handling is a huge, huge problem. And if you look at the bacterial contamination within 4 hours after the food leaves the hospital, the bacterial content is greater than 10 to the power of 5 or 10 to the power of 3. You will find that if this was a restaurant, you will actually close the restaurant, yet we keep giving it into hospitalized patients. And there is enough evidence to show, as shown in these publications listed on the slide, that when you have microbially contaminated blenderized diets, complications are very high, pneumonia, infections, and mortality is also high. If you look at the cost of procuring it, storing it, cooking, handling, transport, wastage, etc., you'll find that kitchen-prepared diets are actually more expensive to the hospital and to the patients. We have to be very, very clear about the continuum of care in the pre-operative period, during the operative period, or in the ICU care, and in the post-operative period. For this, you need an interactive team. A pre-admission assessment is extremely important 10 days prior to any hospitalization for surgery or for chemotherapy or for any other planned treatment, because this is the time you replenish micronutrients, you correct fluid balance, you correct electrolyte abnormalities. This is as important as cardiology or anesthesiology clearance. In some hospitals, I have known that unless the nutritionist has cleared the patient, even if there's a cardiology or anesthesiology clearance, the theater assistant will not even schedule the patient for surgery. So I would strongly urge this becomes the procedure in your hospital. This is the time when decisions regarding post-interventional enteral feeding access, jejunostomy or a gastrostomy or a nasogastric tube can be discussed with the patient. And please try to encourage the use of the enhanced recovery after surgery protocols. The protocol involves over 35-40 components, but of this, early feeding, early mobilization, facilitated by the use of epidural anesthesia. These are all very important components of the ERAS protocol. And so the ERAS protocol, if it is implemented in your hospital, you will find that complications are less, early feeding will be initiated. Here again, you need physician input, and dietitians are a very important component of making sure that ERAS protocols work. For this, we need a teamwork. Now, different hospitals have different teams, and it does not make any difference whether you call it a committee or a formal team or a consultation service. It doesn't matter. All you need is an interprofessional approach, and it depends upon every hospital. But the team, the nutrition support team, has to be given the authority, because every physician cannot be expected to be an expert in nutrition. In the ICU, interprofessional teamwork has been shown to improve patient quality. Nutrition goals are reached faster. Dietitians play a very crucial role. They make sure that parenteral nutrition is used appropriately. Dietitian-led quality improvement optimizes the delivery of nutrition to ICU patients, and the role of the dietitian is to preserve muscle strength, to prevent sarcopenia from occurring in ICU patients. Now, this recognition is not clear all over all of the world, and here is an editorial comment that I wrote with Dr. Gail Krishy, the former president of the American Society, saying that the dietitian is the most knowledgeable member of the interprofessional healthcare team with respect to the identification of malnutrition, macro and micronutrient requirements, and the type of nutrition therapy indicated. So you feel free to quote this to convince your hospital administrators that dietitians need to be involved. Now, lastly, the last part of my presentation are the micronutrient deficiencies are rare. Are they rare? It is an absolute myth. They are very common but not recognized. You do not need to check lab tests. It must be an integral part of nutritional therapy. And this update on parenteral nutrition, of which I was proud to be a co-author, clearly states that whenever parenteral nutrition is used, micronutrients should also be used. And this is an expert consensus opinion to sensitize clinicians regarding the role of micronutrients. A new thing about micronutrients is in the first 3 to 4 days, 100 to 200 milligrams of thiamine are recommended to all sick ICU patients. And because you are not able to reach enteral goals for 4 or 5 days, during the first 4 or 5 days, the patient should get some micronutrients either IV or orally. Micronutrients meaning both vitamins and trace elements. So I'm concluding my talk to also tell you that there is absolutely no evidence to give mega doses of any micronutrient. It is so common to see abuse of zinc during the COVID crisis. And this is a study done by Dr. Gudivada, presently in Hyderabad, AIIMS, earlier in St. John's Medical College, Bayesian multi-treatment comparison. And this clearly shows, looking at close to 5,000 patients, there is absolutely no evidence to support antioxidant micronutrient supplementation over and above the recommended daily allowance present in enteral feeding or parenteral feeding or given orally as a supplement. But please, for heaven's sake, don't give mega doses of any vitamin or trace element in any condition. Thank you very much.